Myeloma Academic Group. So we are back with the Journal Club and other academics through the Indian Myeloma Academic Group. So today we have Dr. Bhausab as the Indian expert, and Dr. Sumit will present on the Perseus study, which is an phase 3 study. So some of you might be knowing about the Griffin study, which was a phase 2 study looking at the addition of daratumumab with VRD, and we have phase 3 study which was presented at the ASH, and then the publication was in New England Journal of Medicine. So after that, we will have instead of Journal Watch, we will have the publications review from the Indian subcontinent, which again would be presented by Sumit only, and then we will have a quiz, which would be conducted by Dr. Arun. So over to Dr. Sumit for the presentation, and followed by Dr. Bhausab, who will give his expert comments on the study, followed by Dr. Shaji Kumar, who is the international experts. So thank you all for joining, and over to Dr. Sumit.
Good evening, sir. I'll just share my slides. Sir, are my slides visible and am I audible?
Yes.
Yes.
Good evening, everyone, and thank you, Team Image, for this opportunity. The Journal Club article today is the Perseus trial. It was published in NEJM in January 2024. This is published and this was conducted by the European Myeloma Network, and this was conducted across Europe and Australia. So starting with the history first, this picture looks like it's like a snapshot from one of the Game of Thrones scenes, but this is actually the picture of the famous Greek mythology hero called Perseus. As per history, it goes that his mother was under the clutches as a slave under an infamous king, and the king had given Perseus the responsibility to slay down a female called Medusa. The Medusa was a female who had snakes instead of hair in the scalp, and anyone who would see her would turn into a stone. So when he was going to slay her in the middle of the night when she was sleeping, with the help of a shield, using her reflection as a guidance, he just slaughtered her with a sword and beheaded her. And he took this beheaded head way back to the king and ultimately relieved his mom, protected his mom from the clutches of that king. And it also says that on the way back, he saw that a beautiful girl was under torture by a sea monster. And ultimately, he rescued that beautiful girl also from the sea monster by using this head in order to stone him down. And that beautiful girl name is called Andromeda. Andromeda is the study of Dara-Sai body in AL amyloidosis. So if you remember, Andromeda had subcutaneous daratumumab. So ultimately, Perseus did marry Andromeda. So if subcutaneous daratumumab was in Andromeda, the same subcutaneous dara has been used in Perseus study also. On a scientific note, Perseus is the name of a constellation in the northern hemisphere, and it looks something like this. So coming to the background, VRD induction followed by autologous transplant, VRD consolidation, and limb maintenance is considered a standard of care for transplant-eligible patients of newly diagnosed myeloma. As per the phase 3 IFM study, which had 1 year of limb maintenance after transplant, the median survival was to the tunes of 4 years in the transplant arm, whereas in the phase 3 determination study, which used continuous limb maintenance till progression, the median progression-free survival improved up to 5.5 years. Now, DARA has been approved for use in combination with BTD, as in the Cassiopeia trial, and in transplant-eligible patients along with LENDEX and BMP. Now, Griffin study, as Dr. Pankaj sir told, was a phase 2 study which demonstrated the feasibility of DARA along with VRD induction, auto transplant, DARA VRD as consolidation, and DARA limb maintenance in transplant-eligible patients of newly diagnosed myeloma. And it showed that quadruplet improved the depth of response and the progression-free survival versus VRD along with transplant and limb maintenance. However, this study, that is Griffin study, was not powered enough or adequately in order to show a difference in the progression-free survival. Henceforth, this study was embarked upon, wherein subcutaneous daratumumab was used along with the same backbone of VRD, transplant, and limb maintenance and it was studied in this study, which is called as the Perseus trial. Subcutaneous dara has been found to be non-inferior to the intravenous daratumumab for efficacy, pharmacokinetics, and significantly less infusion-related reactions, along with an advantage of shorter duration of administration. So herein, they have reported the results of the primary analysis, which is the first interim analysis of a phase 3 Perseus study of subcutaneous daratumumab. So if you look at a study table, multi-center randomized phase 3 over a period of 1 year from January 9 across 150 countries in Europe and Australia. Transplant eligible newly diagnosed myeloma transplant up to the age of 70 years status and a create clearance of were randomized 709 patients in study which had only 200 patients stratified by virtue of and standard risk or one study wherein bortezomib was subcutaneous when the lenalidomide 1 to 21-25 was a low dose dex 14 GB. Importantly, the 8 days, this is in
Is there any breakage of sounds?
No, sir, like we
Yeah.
lost Dr. Sumit very.
I think network issues. We couldn't hear him in between. So maybe network. I'm just trying to connect to Sumit.
Sorry for the interruption. There is some network issue, so I hope so. We will come back with the journal as soon as possible. Kindly stay tuned. Dr. Sumit is joining just in few seconds. Kindly stay tuned. Arun, is there any possibility? Otherwise, we can go to the quiz if it is taking time.
Sir, he's just joining, sir. I think he was utilizing his phone or something for the network. Now he's getting connected to a Wi-Fi. So he's just joining in a minute, sir. I just
Oh.
spoke to him. Sir.
Okay, okay, all right.
Sorry, got disconnected.
Yeah. Dr. Sumit is joining. Just stay tuned with us. Dr. Sumit has joined.
Sir, am I audible?
Yes, audible. Yes.
Please give me 2 minutes. I'll just share again.
Sure.
Sir, is my slide visible?
Yes.
I'll switch off my video because my network is a bit not dicey, in fact, dicey.
Sure.
So
sure.
shall I start again?
No. You can go to the third slide.
Okay. So this is the study design of the Perseus trial. It was an open label multi-center randomized phase 3 study across 115 sites in 14 countries in Europe and Australia. Transplant eligible newly diagnosed myeloma patients between 18 to 70 years of age with an ECOG performance status of less than equal to 2, and those who had a creatinine clearance of more than equal to 30 were included. 709 patients were randomized, in contrast to 207 patients with the Griffin study. Bortezomib was day 14811 subcute. Len was 25 mg day 1 to day 21 in a 28-day cycle, in contrast to Griffin study, which was a 21-day cycle from day 1 to 14 of Len. Dex was day 1 to 4 and day 9 to 12 in this study. After fourth cycle, patients did undergo stem cell collection with cyclophosphamide GCSF-based mobilization. They ended up in a transplant with 200 milligram per meter square of melphalan, followed by 2 cycles of consolidation, which was similar to the induction. After the consolidation, patients did proceed to maintenance, wherein the Len dose was 10 mg from day 1 to day 28. This was in contrast to the Griffin study, where Len was used in day 1 to 21 out of 28-day cycle. In patients on the other arm, subcutaneous daratumumab was added weekly for the first 8 doses, followed by 2 weekly for the subsequent 8 doses, followed by 4 weekly in the subsequent schedule after. So the primary endpoint of the study was progression-free survival, and the key secondary endpoints were more than equal to CR rates, overall MRD negativity rates, where MRD was measured by next generation sequencing, and the cutoff was 10 to the power minus 5, and overall survival. In patients who received maintenance, that is Dara plus Len, patients were discontinued for daratumumab after more than equal to 2 years of doublet maintenance, assuming that they were in MRD negativity state. An MRD negative state means those who were in CR and had at least 12 months of sustained MRD negativity. Patients who did discontinue daratumumab were permitted or allowed to restart daratumumab upon confirmed loss of CR without progression or even on the basis of recurrence of MRD. For example, if the MRD increased by 1 log from 10 power minus 5 to 10 power minus 4, they were able to restart daratumumab therapy. So disease assessments were performed on day 1 of each cycles in the first 6 cycles prior to transplant, and subsequently every 4 weeks for the first year of maintenance, and then every 8 weeks thereafter until disease progression. With respect to MRD, it was evaluated post-consolidation in patients who achieved more than equal to VGPR at the time of first suspected CR or stringent CR, and for those who did achieve CR or stringent CR and remain on the study, was done at 12, 18, 24, 30, and 36 months after cycle 1, day 1, and yearly thereafter. Because this study was from January 19 to January 2020, there were some centers who were affected by closure of the transplant units during the COVID pandemic. In such patients, stem cells were collected after cycle 4 in accordance with the protocol, but transplant was done immediately after completion of cycle 6. The sample size was 690 patients for 85% power and a significance level of 5% to detect the risk of disease progression or death, which was presumed to be 31% lower in the quadruplet group than the VRD group. PFS was analyzed in the intention to treat population, while safety analysis was in patients who received at least one dose of assigned treatment. Data for time to event endpoints, including the PFS, was compared between the treatment groups using the stratified long rank test. Kaplan-Meier method was used to estimate survival. For the key secondary endpoint of MRD negative status, patients who had MRD positive or ambiguous results, or those who were not tested, were considered not to have achieved MRD negative status and are actually included in the denominator. As per the planned study, 2 interim analyses, first at 50% events, second at 65% events were planned, and the final analysis was to be performed after 285 events had occurred. This study, which was published in NEJM, was the first interim analysis, has a total of 153 algorithm-based events, which means that at least 50% of the events had been observed in this study. Coming to the results, the median age was comparable, 61 and 59 years of age. ECOG PS, majority of the patients, that is 90% patients, did have an ECOG performance status of 0 to 1. As expected, the most common measurable disease was IgG type, whereas 8% patients did have a light chain only myeloma. 15% patients had ISS 3-stage disease. This is in contrast to majority of the Indian data sets, which have 40 to 45% patients with ISS 3-stage disease. The cytogenetic risk (17p deletion, 414 or 1416). Coming to the patient disposition, patient who did discontinue the treatment in either of the arms were 25 and 54% in the quadruplet versus triplet therapy regimen respectively. When we look at the reasons for discontinuation, the most common reason for discontinuation was progression, which was higher in the triplet versus the quadruplet arm. However, the death rates were similar in both the arms. When we look at the adverse events for discontinuation, again, intriguingly, it was higher in the VRD arm in contrast to the quadruplet arm. Close to 90% patients completed induction, consolidation, did receive a transplant, and subsequently entered maintenance in both the arms. When you look at the median treatment exposure, almost all the drugs in both the arms were close to 100%, except for the LEN maintenance, wherein the dose intensity was lesser in the quadruplet arm, 85%, in contrast to the VRD arm, wherein the dose intensity was maintained to be almost 100% for all the patients. Coming to the efficacy and safety, the primary endpoint was progression-free survival, and as we can see, the estimated 4-year progression-free survival was 84% for the quadruplet arm versus 67% for the VRD arm. This implies that a hazard ratio of the study was 0.42, which means 58% reduction in the risk of progression or death in the quadruplet arm versus the triplet arm. When you look at a subgroup analysis, the DARA VRD was better than VRD in almost all subgroups, except the age group of more than or equal to 65 years of age, where the 50% confidence interval was exactly on unity. Why is that? We don't know. When we look at the other secondary endpoints of complete response or better, the CR rates were close to 88% in the quadruplet arm versus 70% in the triplet arm, and this was primarily driven by the increased stringent CR rates in the DARA VRD arm. When we look at the subgroup analysis for complete response or better, again, it is better in the DARA VRD arm for all the subgroups. However, for those who are more than or equal to 65 years of age, non-white race, ISS 3 or high-risk cytogenetics, the 95% confidence interval did cross unity, and there was no clear-cut favor of the DARA VRD arm. When you look at MRD negativity rates to the tunes of 10 power minus 5 and 10 power minus 6, overall MRD negativity rates to 10 power minus 5 was 75% versus 47% in the DARA VRD versus VRD arms. When we look at 10 power minus 6 cutoff, it was 65% versus 32%. And most importantly, sustained MRD negativity for at least a year or more was 2/3, that is 65% in those who are in DARA VRD versus only 30% in the VRD arm. This implies that almost 2/3 of the patients in the DARA VRD group who were on maintenance were able to discontinue DARA as per their pre-specifications before, after receiving more than equal to 2 years of maintenance therapy and achieving a CR because they had a sustained MRD negativity for at least a year or more. When we look at the different time points, when we look at the overall 75% versus 47% with respect to cutoff of 10 power minus 5. But at the post-consolidation time point, it was 57% versus 32%, which means that the MRD negativity did improve from post-consolidation when we look at the overall time point per se. With respect to 10 power minus 6 cutoff, in the overall cohort, at any time point, it was 65 versus 32%. But at only post-consolidation time point, it was 34 versus 16%, which means a 30% jump in the MRD negativity rate at some time point in treatment with the DARA VRD versus only a 15% jump with VRD at some time point in treatment. When we look at the MRD negativity rates in different subgroups, it was better for the DARA VRD in almost all the subgroups except for the non-white race. Coming to something which is important, stem cell collection and transplantation. Higher number of patients in the DARA arm required plerixafor for stem cell collection. The median CD34 was also 2 million lesser as compared to the VRD arm. However, this did not impact in the ability to undergo a transplant or the time to engraftment in both the subgroups. So yes, there was some impairment or some degree of less stem cell mobilization and more requirement of plerixafor. However, all the patients who were deemed to undergo transplant were able to undergo and did not and achieved equivalent times of neutrophil engraftment in these patients. Most importantly, coming to the adverse events, as expected, cytopenias, that is both neutropenia and thrombocytopenia, are more in the quadruplet arm. However, the febrile neutropenia rates are comparable in both the arms. Diarrhea and pneumonia, grade 3 to grade 4, were higher in the quadruplet arm. Second primary cancers were also more in the quadruplet arm. Interestingly, fatigue and rash were two side effects which were lesser in the quadruplet arm as compared to the VRD arm. With respect to additional safety information, 78 deaths happened on the study, 34 in the quadruplet and 44 in the VRD arm. 7 deaths happened due to COVID-19. And the most common serious adverse event was pneumonia. Pneumonia happened in 11% patients versus 6% patients in the triplet arm. When we look at the treatment emergent adverse events linked to death, it was comparable, but treatment discontinuation rates were higher in the VRD arm, although serious adverse events were higher in the quadruplet arm. When you look at the safety in patient subset who are more than equal to 65 years of age, and this is the cohort of patients which had did not have a higher efficacy of the DARA VRD versus VRD when we look at the PFS endpoint. So why did these patients did not have a higher PFS? Was it because they did not tolerate this because of adverse events? Let us see that. With respect to grade 3 adverse events, it was comparable in the quadruplet versus a triplet. When it comes to the grade 4 adverse events, it was higher in the DARA VRD versus the VRD arm. However, the treatment emergent adverse events linked to treatment discontinuation was still lesser in those over the 65 years of age in the DARA VRD versus the VRD arm. Treatment emergent adverse events linked to death was comparable or similar in both the arms in those over the 65 years of age. Coming to discussion, the Perseus trial, which used a quadruplet induction, transplant, quadruplet consolidation, and doublet maintenance with an anti-CD38 daratumumab, compared to another arm without daratumumab, so that the 4-year PFS was in favor of the quadruplet arm, 84 versus 67%, with a hazard ratio of 0.42. It was also better with respect to CR rates, MRD negativity rates, and 2/3 on those who received DARA plus LEN maintenance for more than equal to 2 years were able to stop the DARA maintenance after achieving sustained MRD negativity. When we look at the subgroup of patients who are more than or equal to 65 years of age, they had equivalence of DARA VRD versus VRD for PFS. However, the number of events were very small in this subgroup. There was imbalance in high-risk cytogenetics, 25% in the DARA VRD versus 19% in the VRD. CR and MRD negativity rates were similar to intention to treat population. When we look at adverse events leading to treatment discontinuation and death, they were similar to the safety population. While serious adverse events were higher in the quadruplet arm, but adverse events leading to treatment discontinuation was lower in the quadruplet arm. Median CD34 yield in the DARA VRD group was lower, but time to engraftment was after transplant was similar in both the groups. When we compare Perseus and the Griffin study, while both look identical with respect to their layout, where the Perseus study did use a subcutaneous version, whereas the Griffin used an IV formulation. The Perseus study used a VRD backbone, which was 28-day cycle, whereas Griffin used a 21-day cycle. In the Perseus study, almost all patients did undergo stem cell collection with cyclophosphamide, that is chemomobilization, whereas in the Griffin study, they underwent with the conventional GCSL plus Plerixafor mobilization. In Perseus, the Len dose was 10 mg daily, day 1 to day 28, whereas in Griffin, it was 3 out of 4 weeks. And after the first 3 cycles of maintenance in the Griffin study, patients did receive a higher dose of Len maintenance, that is 15 mg once a day. So the number of patients were 709 in Perseus versus 207. Median follow-up was close to 4 years. Interestingly, the median CD34 collected in the Perseus was much lesser than the CD34 collected in the Griffin study. And it is important to know that in both the studies, there is a difference in the Len duration which the patient received in induction, whereas the number of daratumumab doses were the same. When it comes to the estimated 4-year progression-free survival, it is comparable in the DARA VRD in Perseus versus Griffin. More than equal to CR rates were also comparable. But importantly and intriguingly, the MRD negativity rates 10 power minus 5 or 10 power minus 6. Both the studies measured by NGS, clonoSEQ version 2.0, and the cutoff of being 10 power minus 5 was 75% versus 64%, and 65 versus 36% in the Perseus versus the Griffin study. If you look at a sustained MRD negativity rates, it was much higher in the Perseus versus the Griffin study. When we look at a head-to-head comparison of the current triplets in combination with transplant followed by Len maintenance, the median PFS as per the IFM study is close to 4 years, whereas for the determination study is close to 5.5 years. In the Forte study, which used a different proteasome inhibitor, that is carfilzomib, the 4-year PFS in the KRD transplant arm was close to 70%, which means 50% alive without progression at 4 years and 5.5 years when you use VRD followed by transplant. 70% alive at 4 years without progression when you use carfilzomib. When you look at the quadruplet, the first in the Cassiopeia study, the median PFS is not being reached in the DARA VTD arm at a median follow-up of close to 4 years. And when you look at the Griffin and the Perseus study, close to 85% patients are alive without progression at 4 years in comparison to close to 70% with the triplets. Some drawbacks: high-risk cytogenetics in this study included L17P, 414, and 1416, but there is no data for chromosome 1 abnormalities, and we know that it is present in approximately 40% of newly diagnosed myeloma patients. This study did compare a 4-drug versus 3-drug regimen like many other trials in myeloma. How about comparing a 4-drug versus 4-drug, wherein instead of DARA, use cyclophosphamide and see if the outcomes are more or less comparable because this is a cheaper drug. Now, this study did not show a difference in overall survival between the 2 regimens. However, it is important to note that the salvage regimens are not defined. In a country like India, where daratumumab is expensive, we need to define the optimal place of daratumumab in the sequence of treatment, especially when finances are involved. When you look at DARA VRD as frontline treatment versus VRD as a frontline treatment, followed by daratumumab-based salvage regimen first relapse, if you look at overall survival in both of these strategies, and if they are similar, it would help us place daratumumab in the first relapse if the overall survival is similar in both these strategies. Coming to the added value of daratumumab in maintenance, is it a question mark or a certainty? Now, all patients in Perseus and Griffin did receive daratumumab in maintenance. can we rationalize it because we know that all patients, especially in our country, may not receive it. Now, as per the updated results from the Cassiopeia trial, which was published a few days back, or it was available online a few days back in the EHA 2024, if you look at all the three curves, those who received DARA in induction or in maintenance or as a part of both induction and maintenance, all the three survival curves clustered together. Now, this is a snapshot from Twitter. If you look at only the arms of DARA VTD, that is DARA in induction and maintenance, and compare it with DARA in induction without in maintenance, there is some benefit of DARA in maintenance to the tunes of 10%. Does this mean that we should use DARA for all patients in maintenance? Is still a question mark. Now, there is the only available data till now wherein they have compared a DARA-based maintenance versus a LEN standard of care maintenance is in a retrospective real-world study from the Emory University. This was an ASH 2023 oral presentation. 1,000 VRD patients versus 326 DARA VRD patients. None of them received a consolidation. All received LEN maintenance if they were standard risk, or triplet if they were high risk, and none of them received daratumab in maintenance. The median follow-up was understandably lesser in the DARA VRD versus the VRD arms. And the results are identical to that in Griffin and Perseus study, wherein the 4-year PFS is close to 85% and the median PFS is not reached in the DARA VRD arm, which means without using DARA in consolidation or maintenance, the survival curves are almost similar to what we see in Perseus and Griffin. However, cross-trial comparisons should be made with a pinch of salt. Now, two future studies which will highlight us and tell us whether daratumab should be used as a component of maintenance or not is one is the GMMG study, wherein they will randomize patients to LEN or LEN plus anti-CD38, and another is a SWOG study wherein they will randomize patients to LEN or LEN plus anti-CD38 combination. And hopefully this will tell us whether daratumab deserves a role to be placed or used in maintenance. Coming to the conclusions, the quadruplet DARA VRD improved a 4-year progression-free survival, CR rates, MRD negativity rates, and 2/3 of those on DARA plus LEN maintenance were able to stop DARA because they achieved a sustained MRD negativity. The safety profile of the quadruplet was considered safety profile associated with the subcutaneous DARA and the VRD. And investigators did conclude that the quadruplet induction consolidation followed by doublet maintenance represents a new standard of care for transplant patients with newly diagnosed myeloma. Thank you, and apologize for the technical issues.
Thank you, Dr. Sumit. Over to Dr. Bhausa for your comments.
Thank you, sir, and thank you, Sumit, for the really excellent overview and also the analysis in the end. And as Sumit has said, I think this study clearly put a very nice question against the current standard VRD transplant and the maintenance LEN versus the additional value of daratumab in this sequence. Though he pointed out daratumab was used throughout and it is difficult to dissect out value, but if you take this as a package, then there definitely seems to be a benefit to this combination in terms of PFS. This PFS was bound to be there, but I'm impressed by the margin with which it has come positive. It is quite a bit of a difference in this, and as he said, this is the best PFS we as of now had. This study was more for non-US population because of its nature, European and Australian, and Americans had already moved away with the Griffin data. So definitely we'd like to hear Dr. Shaji's comment on that also. One interesting point is the tolerance, sir. I think the tolerance was good. We saw the DARA studies in the second line and beyond, and we saw quite a bit of pneumonias and those kind of things. So definitely there we need to be watchful about the infections in this patient population, but that seems something doable as well. In terms of MRD negativity, I think we have certain insights, like 2/3 of the patient were persistent MRD negativity. So definitely that is, these people are able to come off the DARA. So that also probably to my mind is a very important point. More than 2/3 of your patient can come off the DARA, maybe at the later time point, but that is something to look for. As he clearly showed, the tolerance in the elderly was not really that bad. So definitely this is not an elderly patient population study, but 65 to 70, but fit patients. So definitely this is good. And as you pointed out, stem cell yield is something which we have to be thoughtful. So definitely we should not delay our harvest if someone is receiving DARA-based treatment. So that's a rapid fire on this study on my side, sir. And let's see if we can have Dr. Shaji available, or we'll get his thoughts. So Pankaj sir, I think
Shachi, would you be able to speak, or should we read your comments? Dr. Shaji Kumar is actually in a flight, so
yes, sir.
Go ahead and look at the comments. I'll try and
okay. So I can read Shachi's comment. So the first thing is that at least in the Western world, with this information, the practice has moved from 3 to 4 drug regimen. So there, the things are clear for newly diagnosed multiple myeloma patients, irrespective of risk stratification. So for all patients with standard risk as well as high risk, almost all patients are on DARA RVD, and now we know the information which is coming up from the future phase 2 trials is replacing bortezomib with carfilzomib, and we have discussed some of those those articles in the past. So according to Shaji, there are two things which are important. One is the lack of benefit for the older patients, and this is because there is a likely to be a ceiling. There is a benefit ceiling for response depth in the older patient. And the second point is that it does not tell us whether we need both the drugs for maintenance or only len is sufficient. And in the practice at Mayo Clinic, they have been using lenalidomide as the maintenance for standard risk, and bortezomib and lenalidomide for high risk patients. So one thing is clear, that the patients who are high risk patients, they require 2 drugs maintenance. And it is heartening to note that instead of Dara-Len, they are using bortezomib, lenalidomide as maintenance for high risk patients. The next comment by Shaji is discontinuation rate is misleading, as 4 drugs will take more time to discontinue than 3 drugs. So I think that is a very valid kind of observation. So these are some of the observations by Shaji, and anything else, Shaji, if you are able to say something more. I think, okay. So one of the good thing, is that even if the patient are not able to afford DARA, I think all patients who are receiving VRD, we are, at least for next 4 to 5 years, they are doing good. 67 months is the median PFS. So almost 5 years, I would say. So, somebody who is newly diagnosed multiple myeloma patient, so if he's on VRD, so you can say that at least for the next 5 years, most of those patients will be doing fine. And if the patient can afford DARA, then this is almost going beyond 7 years. So these are, very good times for multiple myeloma patients, that we have been able to achieve this much progress in their controlling the disease. So Arun has raised a question. Arun, yes.
So this was regarding one of the comments which I think regarding the external validity of what the trial investigators approved here in the Perseus. Actually, I would say they cherry picked the fittest myeloma patients who could ever be, because you'll see that 2/3 of the patients were ECOG 0 and 1/3 of the patients were actually ECOG 1. And the median age was close to 60. And they could not prove a benefit of intensifying it with DARA when the age was 65 and above. So what I was saying is we didn't see too much of toxicity because the patients were the fittest of the lot even to start with. But I think in our practice, when we see, sir, what I would say is most of our patients have poor PS to start with. And I agree that even there is subset analysis where DARA does well in frailty group as well. But I just thought, did the trial choose the fittest patients to make a point here? That is my question to all the people out here, sir.
Sorry, I missed your question. So can you repeat the question? Sorry, Arun.
So, okay, am I audible, sir?
Yeah, you're audible.
Yes.
Yeah, but
So-
I missed the.
So what I was saying is the trial actually cherry-picked, I would say, the fittest myeloma patients who could ever be. So they were quite a younger lot. The average age was 60. The PS, the performance status was ECOG 0 in 2/3 of the patients. And I would say ECOG 1 in 1/3. The ISS stage was predominantly 1. And what I would say is they choose a set of patients who are too fit for any regimen to be. So did actually what the trial did was cherry pick patients who were the fittest of the lot, then put them through a quadruplet and intensive therapy, and they said DARA was tolerable in the subset. But in the subset of patients, what we see on routine basis, what I was saying is the median age is close to 60, 65 rather. Most of our PS performance status of the patients are close to ECOG 2 or 3, at least in the upfront. Our ISS stages are mostly 2 and 3. So this, I was doubting the external validity of such a
Okay, got it.
the point. So that was
Got
what I
it.
was.
So I think we must
I would
understand.
push back on that one, Pankaj. So I think, this is a transplant eligible patient population. So by definition, they are fit. So I wouldn't say that it's necessarily cherry picked. It's the population that we would consider for transplant, and within that patient population, the data is valid.
Right. And the second thing I would add here is, the study was done, I think, for getting an approval of DARA to be used in combinations with VRD. I mean, that is okay to look at the 4-drug combination versus a 3-drug combination, but I think the study was designed. One of the point was to get the approval of DARA in combination with VRD. That is one. The second is, as Shachi has already said, that this is a transplant eligible patients where they want the patients to undergo a transplant because that was the arm post DARA RVD. And obviously, whenever we are doing a trial, there are inclusion-exclusion criteria, and that population is totally different than the real world. And that's why, we publish the real world data. We always ask what is the real world data, and real world data is always different than what is the trial data. So we must understand that the trials are done in those patients who have normal kind of renal functions, normal cardiac functions, and they are generally fit enough to undergo the trials. That is the requirement of the trial.
Pankaj, I think it's important to look at this data in the context of the IMROS trial too, right? So I think what we're increasingly looking at is basically a gradual de-escalation of therapy as we go up on age and frailty. So you start with a quadruplet plus transplant, and it's a quadruplet alone without transplant, and it's a triplet. And the three factors that drive the selection will be age, frailty, and genetics.
Right. So yes, Arun, you were saying something?
No, sir. Like I thought, sir, we could not tease out whether DARA was helping us upfront or maybe in consolidation or maintenance, because we used a very good consolidative arm in all our patients. We transplanted most of the patients. We did use a LEN backbone in most of our patients. So I at the end of the day, I'm not very sure whether DARA in consolidation or maintenance really pushes the sustained MRD negativity part. That is what I thought was another thing which was missing, and definitely that was not the primary endpoint of the study also. So these are things which I think will help us reduce the financial toxicity as well if we have a problem to use DARA such in continuous fashion. in our settings.
No, that is a very important, and financial toxicity is not only for us, even if it for the Western world also, financial toxicity plays a very important part. And that's why Dr. Shaji has said that they are not using DARA as maintenance therapy in all these patients. They are using lenalidomide, and in high-risk patients, they are using bortezomib and lenalidomide, and they are not using DARA as maintenance therapy.
Yes. Yes.
Yeah.
Yes.
Pankaj sir, this ASCO, they presented the MRD data on this study, saying especially focusing on the consolidation and maintenance MRD. And though this is kind of surrogate, but surprisingly, they could have 2/3 people MRD negative with continuation of DARA and LEN versus LEN alone. And as Sumit was pointing out in his discussion, definitely this is not a study to dissect out its value, but definitely this seems to be working in that setup as is shown from the Cassiopeia data also. And so one thing was, despite continuation of daratumab so long, we didn't have that much of adverse effect as we anticipated. So looks like after you are done with your induction and consolidation and person is fit, the maintenance administration doesn't seems to be a challenge because it was 100% dose intensity maintained for at least DARA. But definitely not a point for giving DARA for maintenance as of now.
Yeah. So, Bhausab, your question is valid. So I think there is an ongoing SWOG trial which would answer the use of maintenance DARA. What is the benefit of maintenance DARA? And as everybody has pointed out, financial toxicity is the major part. So you have to weigh the risk and balancing the rest of the things with financial toxicity to see whether DARA really benefits in the maintenance arm or not, or versus, and that too, we have to divide the patient into standard risk versus the high risk patient. So probably in standard risk, LEN would be okay, but for high risk, I think we would look at whether Boti-LEN is good enough or DARA-LEN is good enough. So that obviously will take time. I don't know whether Shaji, do you have any information on DARA-LEN maintenance versus Boti-LEN maintenance? Anything? I don't remember
So
anything.
there isn't any direct comparison, but if you look at the Maya study, the median PFS for the high risk was 45 months. And that you could think about it as almost like a maintenance, but of course there's no transplant.
Okay. Thank you. Arun?
So this question is to Dr. Shadi, sir. Like, I just want to know, is there any patient who is not eligible for DARA? Because with the Maya trial and with the Perseus and the Griffin, I don't think there is any person who would be ineligible for DARA. So when we talk about treatment of myeloma in the West, they talk about every patient should be on its clinical trial. So outside of a clinical trial, is there any patient who in real world practice whom DARA is not to be considered? Is there any such patient? I would say it's only a finances which would preclude a patient out of DARA. So is DARA discussed with every patient who walks into a myeloma clinic? This is another question I would want to know.
Yeah, I think the basic foundation will be daratumumab and lenalidomide for every patient. And then depending upon a variety of factors, you can add on third, fourth drug to that and add on transplant as well. But I think the anti-CD38 plus lenalidomide could be kind of a basic foundation.
Thank you.
Do we have any questions from the audience? Okay. So I think we now can go to the second phase of today's academic. So again, going back to Dr. Sumit, who would present the studies which have been published from the Indian subcontinent in 2023.
Am I audible and is my slides visible?
Yes, Sumit.
Okay, I keep my fingers crossed for now. So, this is publications from India in plasma cell dyscrasias field for the year 2023. To the best of my knowledge, And I apologize if I have overlooked any other article. There were 69 articles from India in the period from January to December 2023. I have notified, or I will discuss today a few important original articles. These 69 articles include case reports as well as review articles. Few original articles we will just go through today and see what has happened in our country in the last 1 year. We will divide them into clinical as well as lab perspective. With respect to clinical perspective, with respect to either induction treatment newly diagnosed myeloma, those pertaining to pre-transplant, during transplant, and post-transplant issues. With respect to lab perspective, those from the marrow and peripheral blood tissues, those with respect to serological tests, and coming to the preclinical data. So with respect to clinical perspective, that is induction therapy in newly diagnosed myeloma, this was the POM-ACE or bortezomib, pomalidomide, and dexamethasone study from JIPMER, published in Blood Cancer Journal. And as per the impact factors released last month, the impact factor of Blood Cancer Journal is now 12.7. So this was a prospective trial of bortezomib, pomalidomide, and dexamethasone in both transplant eligible and ineligible patients. 28-day cycle, pomalidomide was 2 mg in cycle 1, followed by 4 mg in cycle 2. The primary endpoint was more than equal to VGPR rates after 4 cycles of VPD. Out of 18 newly diagnosed cases, 58 were screened and 34 were actually enrolled and assigned to VPD induction. So 1/3 of the patients, or close to 27% patients, did have a creatinine of more than 2. And this is important because in this subset of patients, we may not be able to give lenalidomide. So pomalidomide is anyways helpful in such cohort of patients. 97% patients did undergo a PET-CT at baseline. With respect to FISH, close to 60% did not have high-risk cytogenetic abnormalities at baseline. Something which we routinely find in Indian cohort of patients is 45 to 50% ISS stage 3, and 10% were only RISS 3 because the majority of patients did have standard risk cytogenetics. At the end of 4 cycles of bortezomib, pom, and dex, 87% patients did achieve more than equal to VGPR, and at the same time point, they did undergo a PET-CT, wherein 50% patients achieved a complete metabolic remission. Importantly, while cytopenias were not that bad, but 2 patients, one because of infection and neutropenia, that is febrile neutropenia, and one with an infection without neutropenia, had a fatal adverse event. The 1-year PFS and OS was close to 70% in this cohort of patients. Coming to any data from the pre-transplant cohort, this is from PGI Chandigarh, prognostic significance of extramedullary disease on pre-transplant PET-CT done in patients with multiple myeloma. Results of the PET-M trial, which was registered as a CTRI. Between the time period of 2014 to 2022, PET-CT was done as a part of pre-transplant workup, and 69 patients did undergo an autologous stem cell transplant. 43 were included. Out of these 43 patients, the median time from diagnosis to transplant was close to a year, with a median age of 53 years. In the pre-transplant response assessment, close to 80% had a more than equal to VGPR with respect to pre-transplant response assessment. When we look at the survival with respect to those who did not have an extramedullary disease, had a better survival versus those who had an extramedullary disease. Although the p-value for this was not significant, when we look at the cumulative hazard for post-transplant all-cause mortality was significantly higher for those patients, or 16% patients who had extramedullary disease in the pre-transplant PET-CT. Coming to stem cell cryopreservation, we all, or majority of us, do cryopreserve our stem cells at minus 80 degrees Celsius with an uncontrolled rate freezing for stem cells. But how many of us do know that we can use these stem cells after how many years of storage? So this was data from TMC ACTREC, wherein authors examined the effect of long-term cryopreservation using a 4.35% DMSO as final concentration cryopreservative, along with methyl cellulose, uncontrolled rate freezing at minus 80 on the viability and colony forming unit of CD34 human PBSCs. Viability was assessed by both the methods, that is trypan blue and flow cytometry based 7 AED. And here you can see that both the methods, the viability was more or less concordant. It is important to know that there were 26 PBC harvest samples with a median cryopreservation duration of 6.5 years, which ranged to as high as 11.5 years. And if you look at the median viability by either of those methods, after thawing, it was more than 80%. Now, this is very encouraging data. When we look at the median CD34 stem cell count in the post-thaw samples, it was 9.1 million. And when you compare post-thaw CD34 percentage and absolute number versus the pre-cryopreservation percentage and absolute number respectively, there was concordance. So along with that, another more colony-forming unit assays were done, which yielded a good proliferation and differentiation potential in the post-thaw CD34 stem cells. So this tells us that yes, cryopreservation PBSCs using 4.3% DMSO with methylcellulose in an uncontrolled freezing method at -80 can allow for preservation of maintenance of viability of these stem cells for a period as long as 8 years. And they mentioned 8 years because 2 patients who had stem cells who were preserved for more than 8 years did have a less viability, whereas all those less than 8 years had a concordance with respect to viability in comparison to the pre-cryopreservation CD34 values. Coming to transplant, there is more and more transplant from data from India, and the data consecutively strengthens. One from Jammu and Kashmir, and secondly from TMC Kolkata, 47 and 78 questions respectively, with a median age of 52 and 59 years. ISS3 in the Jammu and Kashmir data was 85%. Median time to transplant was also comparatively higher, close to a year. Similar times to neutrophil and platelet engraftment, whereas D100 TRM rates is up to 4% and up to 2.4% in our data sets. If you look at a 5-year progression-free survival from diagnosis in the JNK data, it is close to 60%, whereas if you calculate it from transplant time point, it is close to 40% in the TMC Kolkata data. Coming to post-transplant studies with respect to infections, the day 100 response assessment, that's PET-CT and flow, and with respect to relapse post-transplant, with respect to utility of a second transplant. So an elegant paper and a very nice visual abstract from TJ Chandigarh, a single center retrospective analysis over a period of 9 years, 95 myeloma patients. 1/3 of them did receive levofloxacin prophylaxis, whereas the other 2/3 did not. Fever without an obvious focus was in 50% patients. Microbiologically confirmed infections in close to more than 1/3 of the patients, and clinically suspected infections in 5%. CD4 seen in close to 10% patients in this cohort. Similar to the Jammu and Kashmir, that is KIMS data, the TRM was approximately 4%. And importantly, this suggests that there is a higher incidence of infections and TRM in patients from our country. Majority of them do lack clinical localization and microbiological proof of infection. And when they analyzed and segregated a cohort of patients with respect to with and without levofloxacin prophylaxis, there was no difference in the outcomes and the infection profiles. This is a data set from AIIMS, New Delhi, dual assessment with flow and PET-CT after transplant, that is at day 100 post autologous stem cell transplant in myeloma, a prospective study. So 166 newly diagnosed myeloma patients who underwent a transplant and underwent flow and PET-CT at day 100 post-transplant were analyzed. As we can see that those who are flow MRD negative had a better PFS and OS at the post-transplant time point. Similarly, I expected those who are PET-CT negative, which means dual score 2 and 3, versus PET-CT positive, which means dual score 4. They have not included dual score 5 because that means new lesions. So obviously the survival is very bad. And when they amalgamated both flow and PET-CT, we can see that those who are flow negative and PET negative have the best survival. Flow negative and PET positive have somewhat better in comparison to PET positive and flow negative, and lastly, the both positive patients. So when it comes to between flow and PET, flow is any day is better because those who are flow negative but PET positive still have a better survival than the other discordant cohort. Coming to second stem cell transplant, the data from for relapsed refractory myeloma after first autologous stem cell transplant. This is from my previous workplace from RGC at Delhi. 200 patients who did undergo one transplant, out of which half of them relapsed. 2/3 of them were eligible for a second transplant by virtue of age less than 65 and a good performance status. Only 10% of them actually underwent a second transplant. So 9 who underwent a second transplant later and 3 who underwent tandem transplant were collectively analyzed in this 12-patient cohort. And those who underwent a second transplant and median age is 56. 5 patients did undergo a second harvest, which means that even after giving melphalan, we can harvest these patients again with respect to mobilization of stem cells. The day 100 response rate was close to 80%. Importantly, similar time to engraftment as compared to the first transplant, and the median PFS was close to 1.5 years in those who underwent a second transplant. With respect to the lab perspective, first studies from the bone marrow and peripheral blood. So this is one large data set of 1100 patients from Lilac Labs, which is a standalone private lab in Mumbai, wherein they have included all newly diagnosed myeloma patients who underwent FISH for myeloma. The cutoff threshold for DEL 13Q, 17P, and chromosome 1 was 5%, whereas for IGH it was, and trisomies was 10%. FISH abnormalities was seen in close to 70% cases. This is lesser in comparison to the Western data set of close to 90% patients, probably because they receive many samples from outside Mumbai, so there may be some delay in transport, and in those cases, some of the abnormalities may not be picked up because of delay. The incidence of IGH translocations was 26%. So the most common was 414, followed by 1114. The most common cytogenetic abnormalities per se were chromosome 1 abnormalities, similar to the Western data sets, close to the tunes of 32%. And importantly, double-hit myeloma diagnosis was seen in 13% of the patients in this cohort from India. Another data set from AIMS New Delhi, clinical pathological profile of patients with plasma cell neoplasms with special reference to marrow fibrosis and amyloid deposition, wherein the authors did seek to identify the incidence of bone marrow fibrosis and amyloid deposition at diagnosis in various plasma cell neoplasms. Out of 273 diagnostic samples, 90% were of myeloma. And importantly, in 5% of the myeloma patients did have a baseline fibrosis in the bone marrow biopsy. And these patients had a significantly lower hemoglobin as compared to those without. Concomitant amyloid deposition was seen in close to 6% of the patients, of which half of them had concomitant myeloma, whereas the other half had primary amyloidosis. This data set from JIPMER of circulating clonal plasma cells at diagnosis from peripheral blood by multiparametric flow cytometry as a useful prognostic marker in patients with newly diagnosed myeloma. 66 newly diagnosed myeloma patients, of which 26 did underwent a repeat peripheral blood flow after induction for quantified circulating clonal plasma cells. They did associate the circulating clonal plasma cell percentage with treatment responses of more than equal to VGPR, which was labeled as a good response, whereas others labeled as a poor response. There was no association of circulating clonal plasma cells at baseline with either IXS staging, the beta-2 microglobulin, or the albumin. Based on the median values of 0.1% more or less, they segregated into different cohorts. And those who had a more than 0.19% circulating clonal plasma cells at baseline did have a correlation with poor treatment responses after induction. The median OS was 42 months and the median PFS was 39 months in the entire cohort. When we compare high versus low circulating clonal plasma cells at baseline, the median PFS and OS was lesser, but not statistically significant, probably because of less number of patients in this cohort. With respect to serological tests, this is an important and elegant study from PJ Chandigarh. And I always used to think that serum-free light chain assay is much more sensitive than serum immunofixation, and you may escape a serum immunofixation if serum-free light chain is more or less normal. So this study was done to assess the concordance and discordance between immunofixation and serum-free light chain assay results in myeloma, where total 450 observations were done of both immunofix and serum-free light chain assay from both treatment naive and follow-up myeloma patients. In 28% patients, there was a discordance, and the most common discordance was an immunofix which was positive when the free light chain ratio was normal. The other discordance was a small discordance. So the discordance was higher in immunofix positive and free light chain normal patients, and it was more frequent as expected in follow-up patients. So this tells that negative serum-free light chain assay alone may not be reliable for myeloma follow-up. And if you have to put out an algorithm in a resource-constrained setting, wherein if you want to order either 1 or 2 tests, you can follow serum-free light chain measurements on each follow-up till the patient achieves the normal serum-free light chain ratio. And once it normalizes, the follow-up may be done with immunofix. If the immunofix is positive, further follow-up with immunofix may be initiated. That's what authors concluded from their study. Another study from Cancer Institute, Adyar, Chennai, wherein Dr. Nikita Mehra pioneered that studies have demonstrated the analytical sensitivity of multi-turf mass spectrometry by immunoenrichment, wherein they separate proteins by virtue of antibody-based immunoenrichment. Now, in this study, they use a novel, low-cost, reagent-based extraction process for segregating proteins using acetone nitrile, or a chemical method of receptation to enrich for kappa and lambda light chains. 222 serum samples, of which 90% were myeloma patients, and they had corresponding SPEP, immunofix, and serum free light chain assay values. All SPEP positive patients and 98% of immunofix positive patients were identified by this method. And this thereby tells us that this is possibly a feasible, cost-effective method for qualitatively identifying M protein without the need for the conventional antibody-based immunoenrichment. Lastly, coming to any preclinical data with respect to implications for therapy. So this is a data set which was published from TMC ACTREC, spearheaded by Dr. Syed Hassan. The initial publication was done in 2019, which showed that CDK7 inhibitors induce apoptosis in myeloma cells in vitro and in vivo. And an expanded data set was published from the Dana-Farber Cancer Institute in Blood in 2023, wherein they showed that CDK7 is at the center or epicenter of both MYC and retinoblastoma gene-driven oncogenesis in myeloma cell lines. And if you inhibit them, it inhibits both these pathways. The authors in this study sought to evaluate the anti-proliferative activity of the CDK7 inhibitor alone and in combination with the bortezomib in myeloma cells. And they also thought that if they could overcome bortezomib resistance by targeting CDK7 using this molecule. So on the left-hand side is the cell lines of translocation 414, both bortezomib sensitive and bortezomib resistant, translocation 1114 and translocation 1416 cell line. And you can see that on the y-axis, as and when you increase the CDK7 inhibitor concentration, the percentage viability of all these cell lines decrease. Interestingly, the IC50 of a bortezomib sensitive cell line was much higher than the bortezomib resistant cell line, which means that probably that bortezomib resistant cell lines are more sensitive to CDK7 inhibitors than those which are sensitive. And when they looked at the cells or myeloma cells from de novo myeloma patients, again, they replicated the same finding. And in the relapsed refractory myeloma cohort, out of these 5 patients, 2 patients did show an interesting decrement with viability of cells with respect to increasing concentrations of this CDK7 inhibitor. How does it actually act? We can compare it in the sensitive bortezomib cell line versus bortezomib resistant cell line and see that as the concentration increases, the percentage of apoptosis in cells replicated here by the red and blue boxes increase. And it is possibly because this molecule downregulates majority of the anti-apoptotic molecules like MCL1, BCL, XL, and cyclin D1. And it not only promotes apoptosis, but also downregulates important genes like NF-kappa G and REL-A genes, which are important for myeloma cell growth in myeloma cell lines. And it is known fact that stromal cells protect the myeloma cells and give them nutrition and protect them from cytotoxic effects of any chemotherapy. So in an interesting manner, they used bortezomib sensitive cell line either alone or in combination with stromal cells. And you can see that when they were treated with CDK7 inhibitors, both without stromal cells as well as with stromal cells, it had a higher degree of apoptosis. And similarly, when you look at the resistant cell lines, it is depicted in a similar manner, which means that when you combine them with stromal cells, they were not able to protect the myeloma cells from cytotoxic effects of this CDK7 inhibitor. So to summarize, PPD induction newly diagnosed myeloma was studied in a phase 2 study, and it just goes to show that why should LEN in all induction regimens have all the fun. PBC cryopreservation data at minus 80 degrees Celsius was viable after a median time of close to 6.5 years. There are studies which show the importance of PET-CT prior to transplant and in combination flow post-transplant from a country. We have a poor man's daratumumab, that is second transplant in myeloma. Incidence of cytogenetic abnormalities, baseline myelofibrosis and amyloid from centers in Delhi, circulating clonal plasma cells by data from JIPMER, and by data from PGI when you use immunofix still, even when the serum free light chain is normal. And lastly, closing on to the question whether CDK7 is the future. Thank you.
Thank you, Sumit. So today, all the academics actually belongs to you because you have done the Journal Club as well as the review of all the studies which have been published in 2023. And congratulations for for doing all this works. Thank you so much. And since we are running short of time, so in the last, I invite Arun for the quiz.
Yeah, is my slide visible? Am I audible?
Yes, sir.
Is it in the slideshow mode?
Yes, sir.
Thank you. Thank you. So, without any delay, let me just go take you through the quiz. It's basically a relook into what we just discussed in some of the journal club discussion we just had, and a little bit of trivia to spice you up. So, can you see my first slide?
Yes, sir.
Yeah. So this was the first. This is the first question. It is a sitter, I would say, with Sumit actually going beyond his limits of discussion. He actually introduced the mythology behind the Perseus trial. So I would reframe the question as this: of the following images, if image B is Perseus, which of these images would represent the Apollo? That's another trial in myeloma, we know. And I would want you to tell me which of the following images symbolizes the Greek god Apollo. You need to click on the options A, B, C, D. And the fastest finger first at the end of the day gets the prize. I move to the second question that was about the Perseus trial, which was just discussed. You need to tell me what's the incorrect statement with respect to the design of the Perseus trial. So we have 4 statements here. One to do with discontinuation of DARA in the maintenance arm, the methodology of administering DARA and the protocol, the utility of dexamethasone, which is a backbone of myeloma treatment even today, and was a dose escalation of lenalidomide done in the maintenance arm. You have to choose the incorrect statement. I move on to the third question. That's again based on the Perseus trial. You need to identify again the incorrect statement as far as the safety signals from the Perseus trial are important here. So it's about the commonest grade 3 or 4 adverse event, the most common serious adverse event in the Perseus trial. And it's about the dynamics of stem cell mobilization and engraftment when you use DARA upfront in myeloma, or whether all these statements are correct. The next 2 questions are actually, I would say, for people who read about myeloma and follow it up closely. There's a beautiful IFM study, the 20184 study, which actually looked at high-risk transplant-eligible newly diagnosed myeloma, took them through a DARA-KRD induction and consolidation followed by a tandem transplant. This is a point of controversy even today, that how best to treat high-risk myeloma. So this group of investigators put everything onto the patient, a quadruplet induction, consolidation, and a tandem transplant. And you have to identify which is the incorrect statement with respect to the design of the study. What defined high-risk cytogenetics in this subgroup? What threshold positivity for cytogenetic abnormality was identified by the group? When did the stem cell harvest happen? And what was the maintenance therapy in this regimen? The next question is also based on the same study, that when you take up the patient for quadruplet induction, quadruplet consolidation, and a tandem, there were a lot of treatment discontinuation which you could see. What was the single most common reason for treatment discontinuation? Is it the serious adverse events that the patients are put through, or is it just that the disease progresses in high-risk myeloma? Or is it to do with the dynamics of stem cell collection for a tandem transplant? Or is it just the patients withdrew their consent in the study? I know these 2 questions were tough on you. So to conclude, I have 2-3 questions on trivia. So this is an expert group, I would say, which works on a peculiar subset of plasma cell dyscrasia. I want you to tell me which of these organizations has this enzyme, which is actually epicentered on an immunoglobulin structure. Is it the International Myeloma Working Group, the European Myeloma Network, the IKMG, or the International Myeloma Foundation? The next question is something which is close to our heart, where we actually are in myeloma as far as the government priorities goes. So the government compiles a national list of essential medicines, and the latest was compiled in 2022, which finds 384 drugs for the country which are considered essential. A new drug for myeloma was added into this list in 2022. You need to tell me whether it is lenalidomide, pomalidomide, bortezomib, or carfilzomib, which was recently added to the essential drug list. And the last question for the day is a beautiful picture here. And with respect to the image which is shown, you need to tell me what's the incorrect statement. There are 4 statements given here. So this is a beautiful flame cell that we can easily make out. You can see the flames. With that, I conclude and thank you all for the patient hearing. While the results are combined, I'll just discuss the answers in a minute or two. So this is how it is. Dr. Sumit gave over the Perseus and the mythology behind it. Myeloma, if you see, there's a lot of mythology when it comes to naming the trials. So it's the Apollo on the left, the Castor and the Pollux, the twin gods, and the Cepheus. And if you see the Perseus genealogy, you will find Cepheus all the way because the Perseus had to fight with Cepheus to capture Andromeda. With regards to the Perseus trial, the incorrect statement was about how do you use dexamethasone. We assume that dexamethasone, and we use rather dexamethasone basically in a weekly regimen. But you can see in the trial, which was discussed, and the design which is shown, the dexamethasone is used in 4 days on, 4 days off kind of a fashion, even in the induction and the consolidation arm. So that was the incorrect statement. Regarding the safety signals, I would say all these were correct statements. The most common grade 3-4 adverse event was neutropenia in both the arms. The most common serious adverse event was pneumonia. And as alluded to by Sumit, plerixafor was utilized more in the DVRD arm, but the engraftment dynamics and the mobilization was overall similar in both the groups. This was about the IFM trial on tandem transplant. The group did not consider 1q amplification for classifying high-risk cytogenetics in the subset which was studied. The threshold positivity and other parameters are all correct statements. The biggest roadblock for them was when they do that kind of a quadruplet induction and sometimes consolidation was insufficient stem cell collection in almost 8 of the patients studied. That is what happens when we do a highly intense induction and consolidation before we consider the patient for a tandem transplant. This is the International Kidney and Monoclonal Gammopathy Research Group, MGRS. It's a broad entity with a lot of underlying features, and you see it's beautifully epicentered on the immunoglobulin heavy and light chain arms here, the IKMG group. Len was recently added to the compiled list. So we are talking about a quadruplet. Let's see how much of advocacy we can do and keep the eyes and ears open of the government and definitely the Babus. Regarding the flame cell, all these are correct statements. So this is just a recap. These are plasma cells with vermilion staining glycogen-rich fibrils, typically associated with IgA myelomas. They could also be seen in reactive conditions as well. Thank you all for the patient hearing. Nirav, have we found out who is the winner?
Just allow us, sir, 1 or 2 minutes.
Yeah. I think we have 120 odd people still glued to our webinar. With that, I would hand over the proceedings to Dr. Pankaj sir for the concluding remarks, and meanwhile we can get the winner announced.
Yeah, thank you, Arun, for these interesting quiz questions. I think there is one question from the audience. How often is hypogammaglobulinemia faced with DARA use? I'm not sure if there is any study like that. Because hypogammaglobulinemia can happen even with VRD also, but I'm not sure what is the Sumit, if you are there, you have this information from the trial?
No, sir, I don't remember seeing any hypogammaglobulinemia percentage.
Yeah, so I don't think so we have this information, but probably not that significant if you are using DARA. I think the purpose of asking the question is whether there is higher incidence of hypogammaglobulinemia if you are using DARA, which probably I think is not. Then second is what all prophylaxis are used, the standard prophylaxis, acyclovir, Septran, and no antibiotic prophylaxis. Do you have any reservation on vaccination while using DARA? I don't think so. You really wait for 2 weeks? No. So we must understand when we are doing vaccination at the time of diagnosis, the response rates to the vaccination would not be the same as in a normal person or when the person is on maintenance therapy. The response rates would be close to 50%, which otherwise would be around 80% or so. So this is the answer to the audience questions. And Nirav, do we have the result? So the next general club would be on 25th of July, the fourth Thursday, and we will be sharing the information about the journal, about the article, as well as the next time we will have a journal watch also where you can send your commentary. If it is taking time, we can maybe announce it through email and next time.
Hello.
Yeah,
Sir, we have Dr. Deep Ajay Gala from SGPGI Lucknow.
Ajay.
Deep Ajay Gala.
Ajay, okay, congratulations, Ajay from SGPGI, the winner of the quiz. So you will get all the prizes which we have mentioned. So thank you all. Thank you again, Dr. Bhausa, Sumit specifically for doing all the work. Shaji, our international speaker, Arun for the quiz, and the Mice Idea team for compiling all the information as well as the Zoom link and other email communications. So thank you all. Any last minute comment by Bhausa, Sumit, anybody?
No, sir. I think the review of the literature was quite good by Sumit. So thank you, Sumit.
Yeah, so
Thank you very much.
we will compile this information on our newsletter as well as on the website also. So thank you very much, and with that you can log off. Thank you. Take care. Bye bye.
Bye-bye.
Thank you, sir.
Thank you, sir.